Now, moving on to our fourth section, that is, we have briefly discussed in the previous section what was the injuries around the radial side of the wrist joint. Now, we'll be moving on to over the injuries over the ulnar side of the wrist joint. There are one very important ligamentous complex as well as the bone which are also associated with the ulnar side. We'll be discussing the overview and the clinical features of the ulnar side wrist pain, what are the imaging and what is why we need to go for an arthroscopy, especially in this case when there's an ulnar sided wrist pain, and what is the treatment of the ulnar sided ligamentous as well as the bone injuries. If we are having an ulnar sided wrist pain, now this could be usually after a fall, especially when the wrist was an extension and an ulnarly deviated wrist. This could lead to distal-radial joint injury, or DRUJ may be injured with a radial fracture, or this could be resulting in ulnar styloid fracture as well. And important is usually damage could be isolated towards the ulnar styloid and ulnar side, because when there is, especially after a hyperpronation injury, in which there is initially extension and forceful extension along with ulnar deviation. So the most common which are injured around the ulnar side is the TFCC complex, that is called as triangular fibrocartilage complex, which is actually attached. It's just attached to the three bones in such a way that it forms a triangle. That is why it is called as TFCC. This may be torn as well. No, it's a purely ligamentous injury, which will not be visible on X-ray because there is no bony injury associated with it. Other bony injuries which could be associated with ulnar-sided pain is ulnar styloid fracture. There could be damage to the distal radial ulnar joint. The articular surface may get damaged to the distal radial ulnar joint. Or there could be the damage to the certain tendons as well, especially the extensor carpi ulnaris is just going through this area. This can get either entrapped or avulsed or torn due to this ligamentous or even the bony injury as well. And once it gets trapped as well inside this may not be causing the reduction of the distal radial ulnar joint as well. What are the clinical features? The clinical features include pain and often clunk, especially with the ulnar deviation. Ulnar corner is actually examined and there may be tenderness over the injured side. There may be pain of the rotation of the forearm as well, along with the deviation towards the ulnar side. Distal ulna may be unstable, especially with the piano key sign. If the distal radial ulnar joint is unstable, piano key sign would be positive. As I told you, the piano key sign, we hold the wrist in the extension and press it over the ulna for the distal radial ulnar joint. And if it's unstable or there's a disruption of the distal radial ulnar joint, the ulna will move in the anterior posterior plane. Radius may be unstable due to fracture of the radial styloid, or radial ulnar joint may be displaced, or there may be extensor carpi ulnaris injury which may get trapped over the distal ulnar side as well. Now coming to the AP view, this may show avulsed ulnar styloid, usually which can be seen on the lateral X-ray, in pronation and supination as well. And mainly it shows actually the distal radial ulnar joint incongruity. Other options could be is to go for CT. We are suspecting a subtle bony injury or fracture. Then we can go for MRI as well. MRI would probably tell us whether associated TFC injuries or not. Probably not that good in terms of acute injuries, but in the chronic TFC tears, we can MRI would be diagnostics. Other option is to go for arthroscopy. Why arthroscopy still is the gold standard? Because we can not only go for a diagnostic arthroscopy in which we can diagnose whether it's a TFC CTA or what ligament is injured, we can go for therapeutic as well, then we can repair that as well. Now coming to the treatment, if there is acute dislocation of distal radial ulnar joint which is found between the distal radius as well as the ulna. Usually the resolve if the arm is held in supination with the splint for 6 weeks. Occasionally a K-wire may be required from the ulnar side just to make sure that ulna stays in the place, just to maintain reduction. And if the dislocation is irreducible by closed means, then we probably have to go for, this may be due to the trapped soft tissue, especially the most commonly is always the extensor carpi ulnaris. So we have to go for open reduction, remove the extensor carpi ulnaris from the DRUJ, and then go for open reduction and terminal fixation on distal radial ulnar joint. Coming to the treatment, if there is a chronic instability, this may require reconstructive surgery, especially of the TFCC complex. If there is unstable TFCC tear, we have to go for reattachment as well, or this may require repair, and the most commonly it's done by arthroscopy. If there is a displaced fracture at the base of ulnar styloid, this may require fixation in form of tension by construct, or it could also be fixed with a small screw. Or there is acute ECU sheath tear that can be dealt as treated with repair, and usually an above elbow cast can be given in pronation for 6 weeks. In this section, we have basically gone through what are the injuries which can occur on the ulnar side of the wrist joint. As you know, the most commonly it is always the TFCC injuries, which can be acute or chronic, and because they lead to ulnar sided instability, then there could be damage to the distal-radioulnar joint, or there could be ulnar styloid impaction fractures, or simply there could be a tendon such as extensor carpus which may be caught in the distal-radioulnar joint. Usually the mechanism is for these injuries are always splintage, but if there is a chronic instability which may require repair of these ligaments such as distal-radioulnar joint or TFCC complex, and the best way is to go through arthroscopically do the repair of these injuries. Thank you very much. Keep watching sqadia.com.